Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. So in this case, we have a 3-month-old male who presents to the emergency department for poor feeding. Mom states patient has not fed well for the past 3 days. He is having difficulty latching onto the breast and appears to have decreased strength in sucking. Mom feels her breasts are more engorged. Patient has had only one wet diaper today. Mom also reports a weaker cry and poor head control. She denies vomiting, fever, increased work or breathing. His last bowel movement was 3 days ago. Past medical history includes no hospitalizations. Immunizations, he got the hepatitis B at birth, and the 2-month shots were given about 3 weeks ago. He has no known drug allergies. Birth history was normal with a birth weight of 3.4 kilograms. He usually breastfeeds every 3 to 4 hours for 30 minutes. Socially, he lives with the mom, the dad, the 4-year-old sister. Mom is a nurse. Family history, there's a 5-year-old cousin who has developmental delay and gets early intervention therapies. That cousin is being worked up for metabolic diseases. There's an aunt in the family who has myasthenia gravis. There's a 15-year-old cousin who had Guillain-Barré syndrome that mom thinks was related to the meningococcal vaccine. On physical exam, temperature was 36.9 Celsius, heart rate of 130, respiratory rate of 32, blood pressure of 72/48. Height, weight, and head circumference are all at the 50th percentile. In general, the patient is floppy in appearance with a weak cry. Skin, there is slightly decreased turgor, but no rashes. HENT, atraumatic and normocephalic, a slightly sunken fontanelle. Eyes are difficult to open, but pupils are reactive but sluggish from 4 mm to 3 mm bilaterally. Tympanic membranes are normal, throat is normal. There are no lesions, there is no erythema, but the gag reflex is absent. Lung exam is normal, cardiac exam is normal, abdomen exam is normal, GU exam is a normal circumcised male. Extremities, there's poor tone in all extremities. Neuro exam, he has generalized hypotonia, complete head lag, absent gag reflex, poor suck reflex, but normal deep tendon reflexes. So our problem list includes a 3-month-old male coming in with hypotonia and head lag, a poor suck and poor feeding, and a weak cry. He's found to have absent gag reflex and sluggish pupils. There's a family history of developmental delay, myasthenia gravis, and Guillain-Barré syndrome. So in this case, we have a 3-month-old male coming in with hypotonia. So let's go through the differential diagnosis of hypotonia and see what might be going on with this patient. So the first category we can think of is neurologic causes. So let's think about neural causes of hypotonia. And one of the first things you have to think about on a child who's coming in floppy and hypotonic is going to be sepsis, meningitis, encephalitis, something infectious causing these neurologic type of symptoms. So I think things like, again, sepsis, meningoencephalitis is a huge consideration on a child coming in with floppiness and hypotonia. So the first thing to think about, an urgent thing to think about, is sepsis and meningitis and encephalitis. Other neurologic causes can include any type of intracranial hemorrhage, so some sort of bleed in the brain. So an intracranial hemorrhage from various causes, like an AVM that has ruptured, or maybe there's some sort of stroke or a CVA that is causing the floppiness and the hypotonia. So I think that's a major consideration. Also related to the bleed, you can think about things like trauma, and non-accidental trauma or abuse, and head injury, and other causes of intracranial hemorrhage. So I think that's a major consideration as well. Other neurologic things that can give you a hypotonia, things like HIE, so hypoxic ischemic encephalopathy. So if the child was hypoxic for some reason or had some sort of ischemia to the brain for various reasons, that can cause floppiness and hypotonia as well. Other neural things that we can consider would be some sort of toxin ingestion. Different medications, different toxins can cause you to have floppiness and hypotonia. So I think these are some of the neurologic things that you have to consider on a child coming in with hypotonia. That would be the first category. Other categories after neuro, I think we can think about metabolic causes. I think that's a big consideration. So metabolic causes of floppiness and hypotonia. So lots of like inborn errors of metabolism it can cause floppiness and hypotonia. So the different amino acid defects, organic acid defects, I think is a consideration, right? Amino acid defects, along with organic acid defects. So any of these type of things can cause you to have floppiness and hypotonia. So the metabolic causes in this category, other things include lysosomal storage diseases, glycogen storage diseases, anything like that. Then, so a lot of these lysosomal storage diseases. Again, I'm not going to go into details about each one of these, but I think a lot of these can present with hypotonia and floppiness. So again, there's different type of lysosomal storage diseases. There's different type of glycogen storage diseases. Glycogen storage disease can give you hypoglycemia. That can cause you to have floppiness and hypotonia and altered mental status. So I think that's a consideration. Other things that you can consider, like mitochondrial defects. So again, a lot of the metabolic and inborn errors of metabolism can definitely cause this as well. Other things that you can consider would include things like Reye's syndrome. If the child was getting aspirin or had influenza or varicella, you could consider that. Along with Reye's syndrome, you might think about urea cycle defects. Because you have increased ammonia levels in urea cycle defects and also in Reye's syndrome. So thinking about elevation of ammonia for various reasons can cause you to have hypotonia and floppiness as well. Other things can include carnitine deficiency. So carnitine deficiency, another metabolic process that can give you floppiness and hypotonia. And then another metabolic thing that's actually much more common than some of these inborn errors of metabolism, but something like hypothyroidism. Something simple like hypothyroidism can give you floppiness and hypotonia and constipation and different things as well. So I think these are some of the metabolic causes that you have to think about on a kid coming in with hypotonia and floppiness like our child is coming in. And then we can talk about other causes. We can label them kind of genetic or syndromic, I guess, type of causes. So these are kind of genetic as well, but I like to think about these as more metabolic. And then genetic things, so the common things like Down syndrome can give you hypotonia, right? And then other things like Prader-Willi syndrome, many times we'll have hypotonia in the newborn period as well, right? So these are common syndromes that can present in the newborn or neonatal period or early infancy that can be seen with some hypotonia and floppiness as well. Then, so I think these are some considerations to think about as well. Then, so I think you start with these, and then you think about other categories that could cause floppiness and hypotonia as well. The next category I'd like to think about is neuromuscular. So this is more neuro, specifically related to the brain. I think another good approach would be neuromuscular. So let's think about neuromuscular causes of hypotonia in this 3-month-old child. So neuromuscular, I think, would be another big category as well. And in the young period, Something they might consider is SMA, or spinal muscular atrophy. So spinal muscular atrophy can present with hypotonia and floppiness, and the more severe type can present in the young age, at this age, and present with progressive hypotonia and floppiness. A lot of times, another little pearl for spinal muscular atrophy is that the child might have tongue fasciculations. So if you look at their tongue, you might see their tongue having like waves of movement and some fasciculations of their tongue, and the boards like to ask about that with spinal muscular atrophy. So you have weakness and hypotonia and floppiness, but then tongue fasciculations is something that you would see with spinal muscular atrophy. So I think that's an important consideration as well then. So then other neuromuscular type of things, you might think about different muscular dystrophies. Different muscular dystrophies can definitely present with hypotonia. So there's Duchenne's, there's Becker's, there's lots of different ones, right? So, and they have different presentations, and again, you can read about each one of these separately. But some of these that might present with hypotonia at a younger age would be like Duchenne's and Becker's muscular dystrophy. I think that's something to consider as well then. And then you can think about other things. There's this family history of myasthenia in one of the family members. So if mom had it, you could think about like congenital myasthenia or transient acquired neonatal myasthenia. So different forms of myasthenia can present in the newborn period. So congenital myasthenia or a transient acquired neonatal myasthenia gravis can present this way as well then. And then there's different like toxicities. We mentioned toxic ingestion here, but other toxicities can also cause you to be floppy and hypotonic. So aminoglycosides can do this. So if the child happened to be on like gentamicin or tobramycin or some sort of aminoglycoside toxicity can cause you to have floppiness and hypotonia as well. And then in the immediate newborn period, if the mom happened to be on magnesium during delivery and things, then the magnesium elevation and magnesium toxicity can give you hypotonia and floppiness as well. I think that's another consideration as well. Other things you might consider would be things like botulism. Can also present with floppiness and hypotonia, so that's kind of an ingestion or a toxicity caused by the spores of Clostridium botulinum. So that could be a consideration as well. And then some other rare things. There's a neonatal form of Guillain-Barré syndrome. So again, very rare, but something that you could consider. So neonatal Guillain-Barré syndrome. So not Group B strep, right? In newborns, you think about Group B strep, which would be more sepsis and things like that. But GBS here stands for Guillain-Barré syndrome. So neonatal Guillain-Barré syndrome. So different neuromuscular type of things. So these are some of the things you might consider that are more neuromuscular versus neurologic that could present with floppiness and hypotonia. So those are on the differential. And then I think another category that you have to think about, kind of as a bigger category that sometimes we don't think about, is going to be GI causes. So it's not uncommon for young infants, especially, to present kind of lethargic and hypotonic and floppy with altered mental status when they actually have a GI issue. So some sort of GI obstruction can definitely present this way. So it's not uncommon for especially young kids, infants, with obstruction, so like intussusception or an incarcerated hernia or a partial malrotation or a volvulus, things like that, right? So volvulus, malrotation, things like that, intussusception. So all of these things that can give you obstruction, right? An incarcerated hernia, so all of these things can present with kind of obstruction, and in young infants especially, it's not uncommon at all for children who are coming in with apparent neurologic symptoms, especially like lethargy and floppiness, hypotonia, maybe some vomiting, and they look more like presenting more neurologically. They can actually have something going on in their GI tract. So thinking about obstructions and different causes of obstruction, I think is very important when a child comes in with floppiness and hypotonia. So I think these are the big considerations on a child coming in with floppiness and hypotonia, and the differential diagnosis is quite broad, but it could be nice to divide up into different neural causes, primary CNS and brain involvement, versus neuromuscular causes, and then metabolic things, and then some genetic syndromes, and then some of the GI obstruction as well. And so I think this is a nice broad differential diagnosis for a child coming in with hypotonia and floppiness, and what you might think might be going on and be considering, and then start to work out from that perspective. So let's see how this case in our 3-month-old unfolds and see what happens with our patients. So the child had some initial workup and initial labs upon presentation. As I mentioned, you have to think about infectious causes like sepsis and meningitis, encephalitis as a cause of floppiness and hypotonia. So the child had a CBC, which was normal, had an electrolyte panel, which was normal, had a full septic workup, urinalysis was normal, had a spinal tap, which did not show any white cells. And had some inflammatory markers, CRP, sed rate, which were normal, and then had some other labs to look for different metabolic causes like ammonia level, lactate, pyruvate, and that was all normal as well. The child had a head CT to make sure there's no intracranial hemorrhage or bleed, and that was normal. The child also had an EEG to make sure the kid did not have any type of seizure or wasn't like post-ictal or anything like that, and the EEG was normal as well then. So the initial workup it essentially came back negative and normal. The child was started on IV ceftriaxone while the cultures were pending. The urine culture, blood culture, CSF ultimately came back negative after 24 to 48 hours. And then amino acids and organic acids were sent to rule out some of those metabolic causes. And then the patient was on the pediatric floor and was started on NG feeds because of the poor suck and the poor feeding the child was having. Decided to start feeding by NG. And over the next day or two, the child got a little bit worse as far as the hypotonia and difficulty kind of handling even secretions and things. So the child was transferred to the intensive care unit on day 3 of admission because of worsening hypotonia, secretions, and worry about airway and aspiration and things. So for closer monitoring was transferred to the pediatric intensive care unit. Like I said, all the infectious workup came back negative, so the IV ceftriaxone was stopped after a couple of days. Then ultimately the amino acids and organic acids also came back normal. So we then started to rule out some of the infectious causes, the neural causes, the metabolic causes, and that was all normal. And then there was one other test that was sent on the stool that came back positive and gave us the answer, and the stool was sent for botulinum toxin, and the stool actually came back positive for botulinum toxin type A. So the child was actually diagnosed with infant botulism as the cause of his floppiness and hypotonia. So just briefly talk about infant botulism, and then we'll kind of try to understand what happened with this case. So botulism is a neuroparalytic syndrome, most commonly caused by Clostridium botulinum, which really forms spores, and the ingestion of the spores is what causes botulism. So there's different types of botulism. There's foodborne botulism, there's wound botulism, there's infant botulism. So obviously our child had infant botulism, and infant botulism is actually the most common cause or the most common form of botulism, and usually occurs in kids under a year of age, and it could be there's an increased risk and rates in different states like California and Utah and Pennsylvania because there's more botulism or botulinum spores in the soil in those states, so there's increased risk of that as well. So again, it could be it's usually caused by ingestion of the spores, and the spores can be found in soil. They can be found in honey. That's the big thing that we're always worried about, and why we recommend not feeding honey to any child under 1 year of age. So it could be in soil, it could be in the dust, and then it could be in honey and other food sources as well. But the soil, honey, dust are the most common places that you can get ingestion of the spores. So ultimately, you ingest the spores, and then it causes blocking of the release of acetylcholine at the junction of the nerves and the muscle, and that causes paralysis of the muscles then, and that's why you get the hypotonia and floppiness then. So again, like I mentioned, it's usually under 1 year of age, and about up to 30% of cases are reported to be linked to the ingestion of honey. Now, our mom, did not give any history of any honey ingestion at 3 months of age. So that was a little bit unusual. Where did this child get the botulism from if he had not ingested honey? But up to 30% of cases are reported based on ingestion of honey. But they are from spores, ingestion of spores. So could have gotten it from the soil, if it wasn't from honey, how did our child get it? It was a kind of a little bit of a mystery about how he got the infection then. So. And the toxin that is released by the Clostridium botulinum does not cross the blood-brain barrier, but it just stays at the neuromuscular junction and causes the paralysis then. So some risk factors for developing botulism include, as I mentioned, the ingestion of honey, but also living in rural areas, in farming areas and rural areas, because of the soil and the spores in the soil can be a risk factor as well then. So and the symptoms with botulism, they usually develop progressive weakness over about 2 to 7 days, and they usually peak at about 1 to 2 weeks afterwards, and then they slowly get better over time then. And botulism is a descending symmetric paralysis, so it's descending and symmetric, and so that's why you get the hypotonia, the floppiness, and again, initially you get like a poor suck and poor head control. Then you can also get constipation, neurogenic bladder, and you get involvement of the cranial nerve sometimes. You can be hyperreflexic. You get respiratory difficulty given the involvement of the muscles of the chest, and the drooling and secretion issues, and you can also get ptosis of the eyes, so difficulty opening the eyes, and facial weakness and other type of findings then. So typically your workup is going to be negative. You'll do your CSF workup and all your metabolic workup, and it'll be negative, and ultimately the test is by sending the stool sample and having come back positive for the botulinum toxin in the stool to help make the confirmatory diagnosis. The treatment for it is usually just supportive. Over those couple weeks of the symptoms, you just support them, their respiratory status, their feeding status, respiratory, cardiopulmonary status, and just close observation, and you feed them with an NG tube, and then usually can run its course over a couple weeks, and just require supportive care is usually what is needed. And then you should avoid aminoglycosides, so they can worsen the effect of the toxin at the neuromuscular junction. So and no other antibiotics are really indicated at this point then. Now, another option for management is giving botulism immunoglobulin. So there's an immunoglobulin that's available that is that goes against the toxin. So basically that is a consideration in severe patients or severe cases or prolonged cases. So that could be a consideration as well. So it's basically IgG antibodies against the toxin, and it can help with minimizing or hastening recovery, and studies have shown that it reduces the length of a hospital stay significantly, where usually if you don't give the immunoglobulin, children can be in the hospital for about 5 to 6 weeks as they recover and get their strength back and require rehab and PT and OT and speech and things like that. But if you give the immunoglobulin, the average hospital stay is shortened to maybe about 2 to 3 weeks, so that could be one indication to give immunoglobulin as well then. That is an option then. So then for our patient was treated with immunoglobulin, and over a few days started to get he started to get his strength back, and started to improve, and then was transferred to an inpatient rehab facility to continue PT and OT and speech, and then after about 2 weeks of inpatient rehab therapy, he was discharged home back to normal and his strength then. So then the question came, how did he get this infection and get infant botulism? His mom denied not giving any honey. And then upon continuing questioning the mom, mom did indicate that she was taking different nutritional supplements, and one thing she was taking was alfalfa tablets. So she was taking these alfalfa tablets as a nutritional supplement. So it's possible that maybe the alfalfa tablets were contaminated with spores, and mom was taking these tablets, and there were spores in the tablets. So either they were excreted in her breast milk, or she got them on her hands, and then the baby ingested them. But that was a potential source that we could only think about. Alfalfa, and the soil that it grew in, and then it was made into tablets, and maybe there were spores that were contaminating the tablets as a possibility. So that was one consideration. So we don't exactly know how we got the infant botulism, but that was the diagnosis we made, and maybe based on the history, that was the source of the spores. So that's a case of infant botulism presenting with hypotonia, and he had some of the nice symptoms that you typically present with head lag and poor suck and poor feeding, and floppiness and hypotonia, responding nicely to supportive care, and then the immunoglobulin as well. So again, as part of the CRASH cases, I don't go into details for all of these on the differential diagnosis, but you can use this case to read about a lot of other causes of hypotonia and read about them more at length. But again, as part of the CRASH case, we just kind of go over the presenting symptoms, how to think through the case, come up with a broad differential diagnosis, and a little bit about what the diagnosis was on our patient, and then you can read on your own about some of these other disease entities. So hopefully this CRASH case was helpful to you, and we look forward to seeing you at other CRASH cases as well.